Mr. Haislmaier, you're recognized for 5 minutes.
Thank you, Madam Chairman, and Mr. Yarmouth, Ranking Member. I have submitted, of course, testimony which I will briefly summarize. I am a senior research fellow in health policy at the Heritage Foundation, and the testimony is my own and is not and should not be construed as an official position of the Heritage Foundation or anyone else. I'm testifying in response to the committee's request to present the analysis of health insurance enrollment data that I've been conducting, basically looking at the areas that have been most affected by the key provisions of the Affordable Care Act. That would be the expansion of Medicaid and the introduction of subsidized coverage through the exchanges for the individual market and the related rules governing the individual and employer market, particularly the small employer market. I should note very briefly that this is data that I'm using that is drawn from regulatory filings that insurers make in the case of the private market with state regulators. In the case of Medicaid, this is data reported by the states to the Centers for Medicare and Medicaid Services, which publishes it. That data is done periodically, though, in the case of the private market quarterly, in the case of the Medicaid data monthly, though the best and most comprehensive is on an annual basis. When you look at the experience that we've seen in the first 2 years, 2014 and 15, we saw a growth in the individual market from a base of 11.8 million people at the end of 2013. That was pre-ACA. We saw a growth to 17.7 million people in that market. In the employer coverage market, we saw two things. Fully insured, that is, plans where the employer buys the coverage as a group policy from an insurer. Fully insured employer coverage declined from 60 million to 53 million. At the same time, self-insured employer coverage, and those tend to be larger employers, grew by 4 million. The net of those three interactions on the private market was a net increase over 2 years of 2.3 million people with private market coverage. In comparison, over the period, you saw an increase from 60.9 million to 72.7 million in total Medicaid and CHIP enrollment. So what that leaves us with is a net growth of enrollment in those 2 years of 14 million, of which almost 84% was in Medicaid. Now, when we turn to 2016, we don't have full year data yet for either of these programs, but we do have some initial data for the first 3 quarters, and what we see is a growth of a further 842,000 people in the individual market, a further decline of 1.1 million in the fully insured employer group market, a further increase of 776,000 roughly in the employer self-insured market, and a further 2 million increase in Medicaid enrollment. Again, these are preliminary figures, but it looks like by the end of 2016, we can reasonably project that over the course of the 3-year period, health insurance enrollment will have expanded by about 16.5 million individuals, of which 13.8 million would be attributable to public coverage, Medicaid and CHIP, and the other 2.7 million to private coverage. What does all of this mean? In general, what it means is that the experience of the ACA appears to have had 3 significant effects. It has increased the number of people covered by individual market insurance, but a lot of that has been offset by a decline in employer-provided insurance, and it has principally produced enrollment increases through an expansion of public programs, particularly Medicaid, and particularly in those states that adopted the ACA expansion to able-bodied adults. I will be happy, Madam Chairman, to answer any questions the committee may have. Thank you.
Thank you, Mr. Haislmaier. Excuse me. We will now begin our question and answer session. I want to start by, first of all, again, thanking all the witnesses for being here and asking some questions. begin by saying, as a nurse for over 40 years, what I am really concerned about, and as folks in my district call me and tell me the stories that are just so disheartening to me about their access to quality care and affordability, it really just bothers me terribly to know that there are some folks, as I said in my opening statements, that liked what they had and weren't able to keep it, in particular the high-risk patients in our state who were on a plan that the state had set up themselves, and people were happy about it. And in one day, 28,000 people with some pretty serious conditions were out of care. But let me also go to some statistics. Let me first of all talk about the costs, the rising costs, because we hear this every day in our office. 25% average increase in premiums this year for millions of Americans that are trapped on the exchanges. There was a lady in Tennessee who runs a daycare center, and she's on the exchanges, and her deductible went from $2,000 to $9,000 this last year. There's no way someone running a daycare business can afford that. $1 trillion in new taxes, mostly falling on families and job creators, have really hurt people in what they're able to do in their life besides just their health care. It really has hurt them. How about choice? Nearly 1/3 of the U.S. countries have only one insurer offering the exchange plans. In our state, 3/4 of our state only has one option. That's not choice, that's a monopoly. We also see 4.7 million Americans kicked off of their health care plans by Obamacare. And finally, I think you mentioned it, Ms. Turner, as the fact of the failed Obamacare co-ops. We had a co-op in our state that went belly up, and this is a cost to the taxpayers of $1.9 billion, not million, forcing many of these patients to try to find new insurance. And if I could have the staff pull up slide number 5, this is particularly disturbing to me because let's go back to the one with the hospitals, the 80, yeah, there. Hospitals who have been forced to close under the Obamacare, these are rural hospitals. 50% of my district is rural. If you can look at Tennessee, you will see a number of H's that hospitals who have closed in my district. Now, when that happens, if someone has an emergency, such as a heart attack, they're about 40 minutes from the closest hospital because their small rural hospital has closed. This is devastating to communities, not just for care that is provided, but also for recruiting businesses, because one of the things that new businesses will ask is, where's your health care? They want to know that there's health care in that community. So this has really been devastating, and I think that we can't discount these real stories that come to our office and just break my heart that that is what's occurring. So let me ask you, Mr. Haislmaier, Obamacare really focused almost exclusively on coverage. We saw that as they were pushing people into the computer to sign up for that, while neglecting the cost and the access of care. It was just, let's get as many people signed up as we can so we say that this program was successful. If health insurance doesn't cover the care you need, or if you can't afford the deductibles that come with your plan, or you don't have access, then isn't the number of people that are covered really meaningless?
Sorry, it's true that the authors of the legislation prioritized enrollment over cost control, which I think is one of the reasons the public was never sold on the bill, because most of the public wanted the reverse. They wanted cost control prioritized. In terms of the deductibles and in the coverage, the argument had been made indeed by advocates of this law that insurance with high deductibles was of less value. Some even called it junk insurance. The interesting thing is that that's what this law has produced. The reason for that is pretty straightforward. We saw that in other states that had adopted in the 90s similar measures, and that is when the law limits what dials the insurers can turn, they reach for the only dials that are left. So in this case, the only dials really left are to raise the deductibles as much as you can and or to limit the networks. And that's what we've seen progressing in the last several years in plan design in the exchanges, yes.